Hello, everyone, and welcome and thank you for joining us today for Challenges with Cancer, Obesity, and COVID-19 webinar. My name is Mabinti Conte, and I will be your WebEx technical support host. Before we dive into today's meeting, I wanted to provide some quick information on the webinar platform. All lines have been muted on entry and will remain muted for the duration of the webinar. Please submit questions throughout the presentation using the Q&A box. A moderator will ask your comments and/or questions on your behalf at the end of the presentation. If you require technical assistance, please feel free to contact the host via the chat panel, and she'd be happy to help you. Live captioning is available, and a link has been provided in the chat box. We also wanted to make you aware that today's webinar is being recorded. Lastly, we ask that you take a quick moment to evaluate this webinar via the email link provided at the conclusion of this presentation. Your feedback will help inform our future webinars. And now I'd like to turn it over to our first speaker, Dr. Linda Nebling.
I'm not sure if I have the control yet, Mabinti. Got it. Thank you. There we go. Welcome, everybody. Good afternoon. And it is my pleasure to present today the second webinar from the Obesity and Cancer webinar series, the challenges of Cancer, Obesity, and COVID-19. Our speakers today will be from Dr. Barry Popkin, the Keenan Distinguished Professor from the Department of Nutrition in Gillings Global School of Public Health and University of North Carolina, Chapel Hill, and Dr. Jeremy Warner, Associate Professor of Medicine and also Biomedical Informatics from Vanderbilt Ingram Cancer Center and Vanderbilt University Medical Center. Here we go. There we go. Oops. Slow delay. Today's objectives. Today, our webinar will review the current data concerning factors that increase the risk and adverse outcomes of COVID-19 in individuals with obesity, and also review the effects of COVID-19, its risk factors, and impact among cancer patients based on findings from the U.S. COVID and Cancer Consortium. Our agenda for today's webinar is as follows. Besides the welcome provided on behalf of the Trans-NCI Obesity and Cancer Working Group, Dr. Popkins and Dr. Werner will present. And then Dr. Susan Jakowski, Chief of the Health Behaviors Research Branch, will serve as moderator for the discussion section. And as been mentioned, all questions will be held to the discussion section at the end and can be submitted to the chat box for our group to provide and have the presenters respond to. The Trans-NCI Obesity Working Group is a group that has come together to foster the interests of cross-division activities and areas of research collaboration in obesity and cancer. It also supports the development and cancer research priorities. Excuse me, something's come up on my screen here. To address high priority areas of need and fill gaps in NCI's obesity and cancer portfolio. This area is a high priority given the fact that cancer has now been associated with overweight and obesity of 13 different types of cancer. Still getting frozen slow. There we go. Sorry. There are a number of different subcommittees that are available to work in this domain, comprised of staff from across the NCI. Our focus includes treatment and survivorship, prevention, etiology and mechanisms, measurement and methods, health disparities, and time-restricted eating. Some of these activities include not only the subjects for the webinars that we have planned for the next year, but also potential concepts, white papers, and other types of activities for program. The rationale for studying energy balance in cancer is fairly straightforward. 29% drop in cancer mortality rate since the early 1990s. However, the decline in mortality seems to be slowly being offset by the rise in obesity in the global population. 40% of the adults and 18% of children are obese, which represents a six-fold increase in obesity rate since the 1970s in the United States. By 2023, we are projecting that obesity will affect more than 50% of the US adult population. 18% of cancer incidence and 16% of cancer mortality attributable to excess weight, poor diet, and physical inactivity in the United States. So these are areas of lifestyle intervention and prevention that can have an effect. As I've noted, the increased rates of cancers associated with obesity continues to be a major concern. Among those with cancer, a higher BMI may adversely impact surgical outcomes, treatment efficacy, treatment side effects, and also disease-free survival. Preventing weight gain and promoting weight loss, healthy eating, and physical activity may prevent or control some of these side effects, as well as lower the risks of recurrence and mortality. Our lifestyle behaviors have been shown more and more to have this direct influence to increasing causes of cancer. And with the understanding that adipose cells are not inert, they have a major physiological and hormonal impact into our well-being, influencing appetite response and inflammatory signaling through hyperinsulin status, insulin challenges in our system can precipitate increased carcinogenic processes at the cellular level. Other factors, including sleep and physical activity, components of diet, and associated psychosocial, social, and biological underpinnings all combine to create a continuation of this public health crisis. The NCI is funding research to understand the psychological and molecular mechanisms to explain the association between obesity and cancer risk. It's a very complex set of pathways. There's not a single switch that we can go to or drug that we can go to challenge or stop these processes. We are continuing to explore the multiple extracellular and downstream intracellular pathways, which are adiposity and energy balance is modulating all cellular growth, carcinogenesis, and tumor promotion effects. Obesity is linked to changes in metabolism, hormone signaling, inflammation, and the microbiome function, all of which are influencing our cancer risk and response to cancer treatments, recurrence, and our understanding of these mechanisms are continuing to be challenges for future funding. Today's discussion adds to that complexity, bringing in the impact of the coronavirus. The COVID-19 is generating so many new challenges for us at a global level. Caused by severe acute respiratory syndrome, coronavirus 2, or SARS-CoV-2, has created demands to both the obese and non-obese population. We are beginning to support new research to better our understanding of this now under more involved complexity between obesity, the immune response, and the infections. I'm very pleased to provide this site to our current NCI annual plan and budget proposal for fiscal year 22. This includes an obesity and cancer chapter, which outlines the NCI's interests and directions in the domain of obesity and cancer. And you're encouraged to see it if you haven't already. the opportunities there are relevant to both current and future directions the Institute is expanding and developing into. Finally, I would like to acknowledge the many folks who are involved in working with these activities, particularly the Trans-NCI Obesity and Cancer Working Group, which Susan and I co-chair, as well as the Obesity and Cancer Webinar Series Planning Committee, and the individuals who are really instrumental in making today's webinar a reality. At this point, I'd like to transition over to our first speaker, Dr. Barry Popkin. Dr. Popkin is an internationally recognized expert and has been very much involved in the global field of obesity and nutrition. He has extensive history working with both U.S. and low middle income countries in understanding the shifts in stages of transition in programs and policies that bridge into public health, and has worked placing concerns of global obesity, its determinants and consequences on the worldwide stage. His involvement is known, as I said, globally from Mexico, Chile, South Africa, and many other international communities. And he has won many distinguished awards, including the 2016 World Obesity Society's Population Science and Public Health Award, the 2015 UK Rank Science Prize, and the Obesity Society Mickey Stunkard Lifetime Achievement Award. It is our pleasure to welcome Dr. Popkin.
Thank you. So I want to begin with covering these topics briefly, and then we'll move to my colleague, Dr. Warner. We begin talking a little bit about individuals with obesity and how it relates to COVID, going through a meta-analysis we did, then a brief overview of the mechanisms for COVID-19 risk in individuals with obesity, then discussing the vaccine effectiveness issue among individuals with obesity, and finally giving a kind of an overview of some of our surveys and work around the world and the diet and activity changes we're seeing related to COVID-19. To begin with, the U.S. had already by the 1990s achieved a quite high level of overweight and obesity. As you can see here, by looking at us earlier and then the change into the last period when we're moving on 80% of the country being overweight or obese. And I say overweight plus obesity because in most non-Hispanic subpopulations, BMI of 25 and even earlier indicates the effects of obesity on very high increased risk of hypertension or diabetes, depending on the subpopulation group, so that we really need to think globally of beyond obesity and other levels. And then, as you can see here, there's not a single country today with less than 20% overweight and obesity, and the shifts are quite pronounced, even though here we only show the higher levels of linked to the higher income countries and a number of lower income countries. But if you saw the shift at the lower end, it was equally dramatic, and it's going up quite rapidly, 1 to 3 percentage points a year increase in the proportion of overweight and obese. So we started by doing, I should add that our project is done with a series of faculty, myself, Professor Shufadu, and Professor Melinda Beck, and Will Green, running the meta-analysis and doing a whole examination of the mechanisms affecting COVID and obesity. But we also had colleagues from the World Bank and the Saudi Health Council who together funded and supported our research. So this next slide looks at we looked across the globe. We went into the Chinese literature in great depth because a lot of the COVID studies have been there. And across all these studies, we looked at 1,733 studies. And as you can see, we ended up only with 75 that gave us the kind of data on obesity that would allow us to link obesity with COVID and the various stages of COVID. I should add, we really wanted to also look at overweight, but the reality was only one published study provided such data. And it's a big omission because of the important effects of obesity, because of the high amount of visceral fat around because of for non-Hispanic whites, particularly South Asians, East Asians, Indians, Middle Easterners. We've identified these issues quite important ones, and in Africans, we seem to find a very high level of hypertension at very low BMI levels. So next slide. So we we went through all the different stages. So here you can see about a 46% greater likelihood of testing positive for COVID among obese individuals, based on our research. Then you can see a quite large, 113% greater likelihood of going into a hospital if you are an individual with obesity. And this is really much, much larger than we find from individual NCDs like diabetes, hypertension, which have been reported in the media and in the scientific literature. You can see again, going into an ICU, a 74% greater likelihood if you are an individual with obesity. And then using ventilators, again, a 66% greater likelihood, 2/3 greater likelihood of going in for invasive mechanical ventilation. And finally, death. We had almost a 50% greater likelihood, 48% greater likelihood of dying if you're an individual with obesity and you had COVID-19. So that's really the bulk of our major findings around the linkage of an individual with obesity and COVID-19. And all of these results are much higher than individual NCDs for a variety of reasons. Excuse me. There's these mechanistic changes, and then there are others that we went over. There's the metabolic dysfunction, the immune impairments, the active adipose tissue, and what that does is, as Dr. Nebeling noted, and how together these are very important in creating the comorbidities that go along with much of the individuals with obesity. But also there's the physical side. There's the sleep apnea issues, the pulmonary dysfunction, and all the mechanical effects relating to it, on top of the reduced physical activity that as individuals become obese and beyond, we see. So the results are all these things that we noted. And also there are effects on vaccination that have been shown that I'll talk about briefly later. So here we talk about vaccination efficacy. We've noted in two subpopulations. My co-author has done many of the studies on the flu vaccine. She also did some work with some of the preliminary SARS vaccines, and others have done them with the flu vaccine to show that if you're an individual with obesity, the vaccines will be less effective. That is, the two coronavirus vaccines that have been developed before. We don't know really with the new vaccines coming out. What we have is preliminary data showing from the FDA analysis that they combined individuals with obesity with all the other comorbidities, so we can't separate it out, but I didn't see with that any odds ratio analysis or other kind of analysis to understand how the vaccines worked among the obese. And what I did see seemed to suggest that they didn't look separately at the individuals with obesity, which they would need to do because they would have a completely different biological process, I suspect, as it relates to vaccine efficacy. And we need some of that analysis to be done in the future. Clearly, if we see a reduced effectiveness, we'll need to consider whether they need higher doses or what are the issues. But again, that's an important issue we need to keep thinking about as we relate to COVID-19 vaccines. The pandemic has also had other effects. In our country, there's preliminary work to show it's associated with weight gain in some small populations, and the same in Italy. Otherwise, we don't have really serious research on the relationship with either weight loss or weight gain in low and middle income countries. But we do understand that undernutrition as well as obesity are related to significant reductions in immune function and greater susceptibility to COVID. We also are seeing in all the countries in which we've been studying and doing research, large declines in physical activity, just as we are in the US and higher income countries, seeing that even more so. So we have that reduction in physical activity. We have the increased psychological and economic stresses related to that, and the loss of active employment is one major consideration. On top of that, from studies that we've seen from high-income countries and from our work in low-income countries, we're seeing large increases in purchasing of the most unhealthy ultra-processed foods, and additional in low and middle income countries, increased consumption of less nutritious, cheaper food from vendors and stalls in urban areas. While in high income countries and a few others, we're seeing more home cooking. It's not necessarily healthy home cooking. There's only a very small subpopulation in this country that we can identify with moving to truly healthy cooking habits, and that will certainly be the case during this. So even though we have more food preparation, which is important, we don't necessarily have them cooking healthy food. And so we have this increased weight, and we expect we'll see much more. I'm going to give you a sense of an outlying country that among our countries and surveys we did, because I think it's interesting to see that one country, for a variety of reasons, shifted in a different direction. So again, before I go on to that country, population segregation has really affected the U.S., and the very small proportion of our population has truly increased their healthy eating and healthy food purchases during COVID. We really are finding large increases in food preparation, however, in low-income countries from various surveys as well as from all the food purchase data out there. And you can see it yourself if you go into the shelves, and early on after COVID, you begin to see pastas and flours and other things were completely depleted from the aisles of most many grocery stores. But the ultra-processed food purchase increases are not good. As you may know from a very important trial done, a random control trial done at NIH on individuals that were fed an ultra-processed food versus comparing them for 2 weeks of eating a real food diet, they gained 0.9 kilograms in that 2 weeks. And in our country, the norm in our country is about 60% of our diet comes from ultra-processed, really highly processed food, full of additives and other things. And we found in Peru, the one country, a population really moving toward truly or healthier eating, and I'll show you that data in a second. But we're really seeing a lot of food insecure populations around the world, both in our country and elsewhere. And we don't know what that will bring in the future, but we don't expect to see reductions in overweight and obesity. We expect to see significant ones, as well as in lower middle income countries, also increases in stunting. So this is Peru, and this is our team there. We have a cohort, and we called them up a year later with a very short phone survey to find out how COVID was affecting their behavior. And we were quite surprised. First of all, what they told us is that they had heard that eating a lot of fruits and vegetables would reduce the risk of COVID. So they were cutting down their purchasing and consumption of less packaged foods, less sugar sweetened foods in general, and instead we're eating more fruits and vegetables. Now, this is a quite low income population from what you would think of as shanty towns and such if it were in other countries, but a stable population, so slightly better than the poor. And this is what we found there. Wish we had had similar messages coming out in our country. And finally, to summarize, so I've shown you how individuals with obesity represent a really major risk factor for COVID and all its effects and complications related to having COVID-19. The risks for hospitalization are really significantly greater as they are for ICU admission, ventilation, and mortality. There are concerns about the efficacy of these vaccines. I hope that we'll get on a secondary analysis coming out of this data, a look at how individuals with different comorbidities and certainly obesity alone, or possibly also overweight, are affected in terms of the efficacy of the vaccine. And the population is large enough. There's about 35% of the individuals in the Pfizer trial that had obesity, so we're individuals with obesity. So we could certainly be able to analyze that data. The COVID pandemic, as I noted, is linked with really important shifts in food purchasing patterns and reduced physical activity. There will be increased weight gain. This will be an increase in the risks of 13 of the 15 major cancers, as Linda had noted. And in low-income countries, the food insecurity and economic stresses will lead to both increases in undernutrition as well as obesity and increased risks both in the long term for NCDs from either side of that double burden of malnutrition. Thank you very much.
Thank you, Barry. And we will hold questions again till the end of the discussion, to the end of the second presentation, excuse me. My pleasure now to welcome Dr. Werner to present on the COVID-19 and Cancer Consortium, the initial results and an exploration of the role of obesity. Dr. Werner is an associate professor of medicine and biomedical informatics at Vanderbilt University, and his clinical area of focus is hematologic malignancy. His primary research goal is to make sense of the structured and unstructured data presented in electronic health records and clinical knowledge bases to directly improve clinical care for cancer patients. He's also the deputy editor of hemonc.org, which is the largest freely available wiki on chemotherapy regimens. And he is a founding member of the COVID-19 and Cancer Consortium, a member of the steering committee, and a chair of the informatics committee. The CCC19 maintains one of the largest registries of patients with cancer and COVID-19, with more than 125 participating sites and more than 5,000 cases reported so far. It's a pleasure to welcome Dr. Werner.
Thank you. Thanks for the invitation to present to you all. It's really exciting to be here. I apparently have taken backlighting a little too seriously, though, so I apologize for the glow that's emanating from my clothing, which is hopefully not too distracting for you. So I was thinking as Dr. Popkin was presenting about my personal relationship with food and the pandemic. I just have to say that I was doing pretty well with time-restricted eating right until Friday, March 13th, when my daughter came home from school for the next 10 weeks. And that was sort of the end of that. So I definitely have a personal relationship to changes in eating habits as a result of the pandemic. So let me go forward here. So I'm going to talk to you about our consortium and what we found about obesity, which is going to be not in alignment with what Dr. Popkin just presented. And I'm going to try to perhaps bring forward some reasons why, but I also am very eager to hear about thoughts from the audience. So let me first start with a background of our consortium. And then I'll talk about some general factors that we found associated with mortality in patients with cancer and COVID-19, and then a bit about obesity, and then finally looking at some of the treatments that we're seeing for COVID-19 in these particular patients. So like I said, my eating habits changed on March 13th. Well, we founded this consortium 2 days later, that weekend, which is almost exactly 9 months ago. It's hard to believe. But this consortium started on Twitter, sort of a social media phenomenon, which really began when a fellow, actually a resident at that time, Dr. Akash Desai, now a fellow at the Mayo Clinic, started to bring together a number of hematologists and oncologists on Twitter with the idea that we really didn't know much about how patients with cancer were going to do with COVID-19. So let's form a registry and learn about them. There were 5 founding members, as shown there. There's a few overview articles that we've published. We quickly got a logo, a hashtag, a Twitter handle. We have over 1,700 followers on Twitter now, and a website. If you're interested in sort of a quote-unquote biography of our consortium, Medscape wrote us up now in about June. Sort of how we came from nothing to publishing our first paper in about 10 weeks, including an interesting backstory of how we obtained our website. So when you think about cancer and COVID-19, we had a lot of hypotheses about how patients with cancer might have more severe disease, not really too many hypotheses about how they might be protected, unfortunately. But this shows you a couple of the reasons why. Starting in the upper left, if you think about even the virus getting into the system in the first place, or internalizing sort of the critical first step to infection, that is potentially influenced by factors that are present in cancer patients, such as the smoking, or perhaps the increase in age might lead to more ACE2 expression. The cofactor here, TMPRSS2, is possibly upregulated in the setting of androgens. If you look at the upper right, this is really where we think patients with cancer are especially at risk from the virus and COVID-19 for a number of reasons, ranging from disruption of natural barriers, such as cancer directly in the lungs, disrupting the lung tissue, immunosuppression from cancer itself, or certainly iatrogenic immunosuppression through chemotherapy and other treatments. And then, at least in the beginning, we did have concerns that some cancer treatments, in particular immunotherapy, immune checkpoint inhibitors, CAR T cells, might actually hyperactivate or prime the system to have an overwhelming cytokine storm in the setting of SARS-CoV-2, which would, of course, be expected to lead to more severe infections. We are also, on the bottom here, you can see we're concerned about an increase in arterial and venous thrombotic events in patients with cancer. Notice that obesity is not on this slide, and actually this review, which has, of course, now out of date, but when it was published about a month ago, is fairly thorough. Really, none of the published papers that we could find spoke much about the interaction between weight and cancer and COVID-19. This is our website. If in case you wish to visit, we have links to our publications and other information there. This is just to note, again, we started from nothing. By 2 days after the founding, we were up to 14 sites participating, and currently we're at 125 or so, mostly in the US, but also significantly a number in Canada and Mexico. This is our steering committee of currently 9 members, mostly US-based. We are lucky to have Dr. Peters from ESMO as well. This is our mission statement. So our driving goal is to collect and disseminate prospective, granular, uniformly organized information on people with cancer who are diagnosed with COVID-19 at scale and as rapidly as possible. I won't spend too much time on this slide, but this is our data collection schema, which is available online as well as through this publication shown below. Essentially, we collect information on the patient themselves, and that includes demographics, which includes the presence or absence of obesity and body mass index. We collect information on the COVID-19 initial and subsequent course of illness, and then, of course, detailed information about the patient's cancer or cancers in the case of multiple malignancies. Here you can see the number of cases that we've accrued over time now. Again, we started in mid-March, so here we are about 9 months later, and we just passed the 6,000th case. We're just starting to see the third wave in the United States, so I expect that this number, unfortunately, will continue to climb at a fairly steep slope for the next foreseeable months. This is the first paper we published. This came out in June in The Lancet, looking at the clinical impact of COVID-19 on patients with cancer. I'm going to go over some of those results now. And I'm also showing you here results from just a few months later from a data lock at the end of June, where we almost tripled the number of patients in the analysis. So in the middle column, you see the numbers that were presented in the paper. And on the right, in the at a special symposium organized by AACR earlier this summer. So the top line, we're looking at 30-day mortality in these patients, and it's above 10%, certainly, and rose somewhat with the updated analysis and has probably remained in that general area since that time. Our very first report was very soon after the registry got started, so I think we had incomplete follow-up, and that was probably why the mortality number was even a bit lower there. We also see substantial rates of mechanical ventilation, ICU admission, oxygen requirement, and hospitalization. Here we go. So here's a spectrum. So I'm showing you here some mortality for some select subgroups, and comparing it to the global statistics that come out of Johns Hopkins. I actually just updated this. It's interesting that the global statistics have the mortality has gone down. It's now about 2%. But actually in our cohort, if anything, it's gone a little bit up. So as I showed earlier, and these numbers are from that updated analysis from June. You can see there's really only one set of patients with cancer that seems to do about the same as the global average, and that's patients who have a excellent performance status and no comorbidities to speak of, including obesity, which we considered as a comorbidity. And then you see other factors that increase the risk here, the observed risk anyway, those being male sex, having a cancer that was progressing, being older, and having a poor performance status. When you start to look at combinations of these factors, you start to see very high mortalities, although of course your denominator shrinks as you start to look at more and more granular subsets. Nevertheless, you can see the patients, for example, with a performance status of 2 or more who were intubated, actually 75% of them died. We also have a spectrum when you look at specific cancers. I did not label which ones of these may or may not be associated with obesity. You probably know better than me, but certainly some of them are more well known to be. And I believe the correlation is not really there in terms of the mortality. But what you do see is from a low of about 3% for thyroid cancer to a high of more than a quarter of patients with lung cancer who are diagnosed and reported to our registry have died. I'll say that these numbers are actually lower than other registries, both from the United States, but especially from Europe, which tend to collect primarily on hospitalized patients, whereas about half of our patients that are reported are typically with mild COVID or are never hospitalized. These were updated analysis of risk factors that was presented at ESMO a few months ago. And really what I'll just focus on here is the overall, so the middle column. We also looked at a subset of hospitalized patients, again, to try to be a little bit more in line with, for example, those European studies. But if you look, the risks are not too much different between those. And you see that age is a major risk factor per decade. You see the overall risk going up, the overall odds ratio, the adjusted odds ratio. Similar findings as previously for other factors here. Again, obesity being a comorbidity, so perhaps in this number here, adjusted odds ratio of over 2 for patients with 3+ comorbidities, obesity is a factor. But again, ECOG is, at least in this analysis, the largest overall odds ratio. Here are some cancer-specific factors, such as progression, again, being highly associated with mortality. Interestingly, we wanted to know and still want to know, does recent cancer therapy influence risk? And that's not significant in this analysis. What is having a hematologic malignancy or having multiple malignancies. Now, if you've been paying attention, I know you have, I didn't mention obesity in any of those previous slides, and it's because it's been a non-significant risk factor when adjusted for others. And here are 3 subsequent analyses that we've done, and you can see that the number analyzed has increased by 5 times. So in our first publication, we had about 1,000 patients, and our most recent analysis has nearly 5,000 patients. And you can see we've been able to adjust for more and more covariates because of those increasing numbers and increasing number of events. And from the beginning, though, obesity was a covariate. And so what I'm showing you here on the right is that each time we've performed an analysis, it has, there's been really no significant finding for obesity, perhaps a numeric trend for worsening outcome, but but the 95% confidence interval crosses 1, and that's whether you look at 30-day mortality or you look at, most recently, we're looking at an ordinal outcome ranging from no complications to hospitalization, ICU, mechanical ventilation, and death. And in all cases, there doesn't appear to be an association. So what I wanted to do for you all was to try to unpack this a little bit and start the discussion about why this might be. So what I'm going to show you here are unpublished descriptive statistics. I haven't performed any statistical tests on this data, but I think what you'll see visually, at least, is perhaps some explanations. So here is that ordinal outcome, again, the 5 levels as shown. And excuse me, but no webinar is complete without the appearance of a cat. So I'm going to try to, there we go. All right, so what you can see is that with the exception of mechanical ventilation, where the patients do appear to have a higher BMI than the ones with no complications, there really doesn't appear to be any obvious pattern here. Here's a scatter plot looking at age, BMI, and outcome. So the x-axis here is body mass index. The y-axis is age, and then the color of the dots corresponds to those outcomes. I do need to note that we did not collect BMI for about the first month of operations. So the number you see here, which is just above 4,000, is missing about 700 or 800 patients that didn't, and that's my cat advancing my slides. I do apologize. Let me try to get back here. Let's see. Okay, I'm going to go off video for 1 second and remove the cat. I'll be right back. By the way, he's an obese cat, so I think he was just really getting into the presentation. Okay, so I'm going to move on. So I don't think I see any clear pattern here, and I think that you'll probably agree. Here, though, I do think we start to see a pattern. So here is looking at BMI and stratifying it by ECOG performance status, and it's pretty clear to me, at least, that that there's a trend or an association here that the worse your performance status, actually the lower your weight. And this actually makes a lot of sense when you think about what cancer does to people. Often, especially in the later stages, it causes cachexia, and I believe that's what we're seeing here. And here, again, sort of looking at that from a different angle, we're looking at cancer status. So on the top, you see patients who are in remission. The second line are patients who have active disease, but it's responding to treatment. The next one, they have active disease, but it's stable. And then finally, they have active disease, which is progressing. And you certainly see a bulging towards the left here, especially with that bottom with the bottom violin plot. So, I think this is probably going a long way towards explaining why obesity doesn't survive statistical adjustment in our population. So as an interim conclusion, patients reported to our registry have a high burden of disease from COVID-19. And at the most recent analysis, more than half of patients have hospitalization or worse as an outcome. Of course, this may be confounded by selection bias, but again, as I mentioned earlier, our registry, at least as compared to others, has more outpatients, and I think perhaps more accurately represents the true burden of COVID-19 in patients with cancer. Age, ECOG performance status, and cancer status seem to have the largest adjusted odds ratios for poor outcome. As I said, obesity does not meet statistical significance as an independent factor associated with any outcome we've investigated thus far. There are, of course, other outcomes that we have not yet investigated. When we look at the descriptive violin plots, there's no clear association of obesity with age, but a fairly clear trend for decreased BMI with increasing performance status and worsening cancer status. So I'll spend the last 5 minutes or so talking about treatment of COVID-19 in patients with cancer. So this is our second publication that came out in July, I believe, looking at treatment exposures that drugs or other treatments that had a purported positive effect on COVID-19. And you can see here in the table on the left that the most commonly administered drug in this particular point in time was hydroxychloroquine. Its popularity has clearly fallen off at this point, but it was quite commonly given, usually in combination with azithromycin, as you can see from the upset plot on the right, followed by remdesivir, steroids, and then down the line. What was pretty interesting to us is that we additionally asked about whether treatments were given on or off trial, and you can see that for hydroxychloroquine, almost none of those treatments were given on trial, whereas for remdesivir, which until the EUA came was only available through trial, almost 70% of the patients received that particular drug through a clinical trial. Other includes convalescent plasma, and that explains why this number is 40%, because that was also mostly only available through trial. We looked at these treatments sort of in isolation here, where each column represents one of those drugs. And we looked at clinical factors to try to get a sense here. And again, this is descriptive, but to get a sense of what factors might or might not influence a decision to give a certain treatment. And I'll call out to your attention obesity. So it does appear that certain treatments are given relatively more often in patients with obesity, and in particular tocilizumab, which you see as the bright red there, and then high-dose corticosteroids. Getting a bit of a lag here, but I think we'll be okay. Let's see, there we go. Okay, so this is, that was descriptive. This is a multivariate analysis looking at those factors and adjusting for the other factors. Specifically looking at factors associated with the receipt of the combination of hydroxychloroquine and azithromycin, the drug remdesivir alone or in combination, and then any treatment. And again, I'll call your attention to obesity. And here we do have a finding, which is that obese patients were statistically significantly more likely to receive any treatment for COVID-19 than other patients. And so this suggests that there's a degree of medical decision-making going on that's being driven in part by the presence of obesity. I do think it's because all the other literature, as Dr. Popkin presented, has suggested that this is a really significant risk factor in the general population. And I do believe that that would drive treatment decisions. Likewise, if you look further down that column, you see that pulmonary comorbidities drive treatment, sometimes comorbidities drive away from treatment. Cardiovascular comorbidities drive people away from hydroxychloroquine and azithromycin, which makes perfect sense if you think about the risk profile of those drugs. And a renal comorbidity drives away from treatment for remdesivir, which again is the main issue of that drug is renal clearance. This is our attempt to put together a fairly complicated analysis of whether these drugs are helping or even harming. I actually won't dwell on this slide except to say that we recapitulated findings on hydroxychloroquine, which have been also shown in many other studies, that there is no benefit and quite potentially harm. We found perhaps a trend towards improved outcomes in remdesivir, and counterintuitively, perhaps we found an association with increased mortality in high-dose systemic corticosteroids, which is a topic for another day, probably. We did, those results I just showed you were adjusted for obesity, and again, we find that obesity as a covariate does not influence outcome independently, it would appear, in patients receiving these treatments, these three treatments. And you can see what we adjusted for here. This is also unpublished, but this is looking at our more recent data. So again, thousands more than what I just showed you. And this is looking at patterns of treatment with these drugs, which I would say, with the exception of hydroxychloroquine, the others are, to this day being commonly used, and trying to understand if there's a pattern of treatment exposure based on BMI. And I would say certainly that both for remdesivir and for steroids, you see this fairly consistent trend towards increased use of these drugs with the higher BMI. So it does appear that that is still driving, the BMI is still driving decisions to treat, although this is unadjusted and really just shown to perhaps provoke some questions. So, so again, just recapping what I just presented, patients with obesity and cancer appear to be more likely to be offered COVID-19 treatment after adjusting for other factors, including baseline COVID-19 severity. Obesity does not appear to have a statistically significant association with 30-day mortality in patients being treated with those 3 treatments. But there certainly appears to be a trend towards more of those treatments, especially steroids, in more obese patients with cancer, despite an unclear demonstration of efficacy. And next slide is my last slide. There we go. Of course, I'd like to acknowledge the patients and their families. This is a huge effort. We have more than 450 active participants in our consortium now. I do always want to thank the Feinhorn Foundation for transferring the website to us. We're very grateful for the generous support of the NCI and other funding institutions to help make this work happen. Thanks very much, and I look forward to the questions.
Well, thank you so much to our panelists for really these outstanding presentations. My name is Susan Chakowski. I'm Chief of the Health Behaviors Research Branch at NCI, and it's really my pleasure to moderate this discussion. We already have some questions, I know. And please, if you have questions, put them into the Q&A section. And I think we will get started with some questions for our panelists. Really, I had one question I'm quite interested in for both Dr. Popkin, and then I'll ask it as well of Dr. Warner. Dr. Popkin, what do we know, if anything, about obesity and the long-term COVID effects, so the so-called long hauler syndrome? And are there plans to look at some of these longer-term effects and associations with obesity?
I really can't answer that at this point. We really don't have those kind of studies and data yet. I'm sure there are effects, particularly because of the lung function issues, but I can't say more. Maybe Jeremy can.
Yes, I was going to say, Dr. Warner, do you have any data or are there plans in your consortium to follow these cancer patients for long-term effects?
Yeah, so I like to, when we talk about our consortium, I like to say it's really true that we've been building the airplane in the air. So when we began, we didn't really think beyond, we're like, oh, we just need to collect 30 days of follow-up and that's going to be enough. And clearly that's not enough. Fortunately, even though the mortality is high, there are many survivors, right? So we now collect 90-day and 180-day outcomes, but will that be enough? I don't know. We'll probably have to go longer than that. I do think as I showed in my sort of second to final slide there, steroids are pretty popular to treat COVID-19 these days. And I don't think that's going to help obesity. It might be short course, but sometimes it's not so short. Plenty of people get 10 days of high-dose dexamethasone, and then perhaps are on a slow taper if their pulmonary symptoms do not resolve. We've certainly seen that patients with hematologic malignancy can have prolonged viral shedding and prolonged symptoms, and they may end up on steroids for a very long time, which will certainly not help with their body mass composition. And I suppose there's questions of sarcopenia and the like, but I think we're going to have to gather that data and figure it out in sort of a in a longitudinal manner, whether it be through our consortium or through other more prospective trials.
Yes. So lots there to continue to keep an eye on. Let me ask a question for Dr. Popkin from the audience. Joyanne Rohan has asked about the study in Peru. So there was an indication that folks had heard that vegetables and fruits were better for you. Was there any indication that about messaging? How did they hear this? Was it rumor? Was this something possibly put out by authorities? Or
yes, it was. There was no messaging, and in fact, we've done these surveys in 6 countries, and we haven't really seen the kind of messaging beyond just dealing with COVID protection about healthy living, healthy eating, try to be active, etc. And in the case of Peru, what was unique was they had a complete lockdown. In fact, the military patrolled the streets. You couldn't go out. So it was a serious lockdown. And so that's all I can say.
Okay.
And so I think it really happened through rumors and through Facebook and websites and tweeting. In their case, WhatsApp is a very huge popular option. So that's all we know. It was quite surprising. We followed the media completely in a couple of our countries, and we haven't seen either from the government any discussion beyond dealing. They're so focused on dealing with the calamity in terms of their health systems. There's been no focus on encouraging people on what to eat or how to move.
Right, right. Well, thank you for that answer. Dr. Warner, we have a question about, did your analysis look at current weight and BMI among patients with cancer? Given that cancer patients, and especially those with progressive disease, have likely already experienced weight loss. So would that perhaps skew your results in some way?
Yeah, I mean, there's so many caveats, and one of them is, just the practicalities of getting this done, or actually getting these cases reported are such that we do not ask for repeated measures of things such as weight or laboratory values. So we essentially collect weight at baseline or sort of at presentation. This is a great opportunity for electronic health records. You noted in my introduction that I'm an electronic health records researcher, and certainly before I pivoted to COVID-19, that's most of what I did. And so right now our survey depends on an army, if you will, of manual entry. We are thinking of ways to pivot to a more automated collection. Certainly there are others at the N3C effort through NCATS and others that are leveraging the electronic health record environments that most institutions have now, of course. And so we're thinking about that, but we certainly don't want to ask our survey respondents to go back and enter serial weights, over a prolonged period of time. So that's just sort of a practical trade-off, but it's a great point. It's a great point.
Great, thank you. I'm Dr. Werner. I'm going to stay with you for the next one. The racial disparity for COVID-19 outcomes has really received a lot of attention, as you know. And from your data and experience, do you have any thoughts about mechanism or interpretation of this disparity? And
so I want to say we're right in the middle of a new analysis looking specifically at this question for in particular looking at non-Hispanic Blacks versus non-Hispanic whites. And we think, our hypothesis is that these findings are driven by socio-demographic factors and not anything innately genetic or related to the underlying individuals, but and I think that's there's some very recent data, not on patients with cancer, but more generally, sort of supporting that assertion. So I believe that's one thing I can say is that we certainly see that non-Hispanic Black patients present with a higher severity. So they present, by the time they present, they have a more severe case, and that has a great effect on how you're going to do. Really, now why is that? I can't answer that right now because we're in the middle of the analysis, but it seems to me that that's going to be related to socioeconomic status, access to healthcare, access to tertiary care versus not, and so forth. So I do believe that those are the major drivers that I believe we're going to see.
Thank you. Thank you. A question for Dr. Popkin. What is it about obese individuals, do you think, that makes the vaccine less effective on them? Do you have speculation about that?
No, the research on mice and humans with the coronavirus flu vaccine have kind of indicated a lot had to do with T cell changes and the immune impairment, but it also came through the adipose inflammation. So there are these two pathways that come together, and we have to remember that obesity is a cumulative process. These are active cells, as Dr. Nebeling said, living cells, and they actively are producing this inflammation and T cell responses over time. So this is an accumulative impact. And as is the case with cancers and their effects on our system. So that we don't have like a study on just becoming obese. We have studies on obese individuals, and most individuals age 40 and beyond have been obese for quite a while. But I should add something on the ethnicity issue. We must remember Native Americans first, and then African Americans and Hispanics have very high levels of obesity, BMI levels over 35, 40, 45, much higher than among non-Hispanic whites. So that when we think not only of obesity, but extreme obesity, then we begin to see an additional risk factor that comes into play.
That's interesting, and it brings up a question. Have you looked at, in fact, different levels of obesity and separated those out through morbidly obese to...
Again, the data wasn't there. These were meta-analyses, and they weren't there. We don't have access to a database like Dr. Warner. And if they had a control that went with their database, they could clearly look at all these issues separately and in various ways with other controls.
What I will say is that following along that, we just presented some data at the American Society of Hematology at the ASH conference on thrombosis in patients with COVID-19 and cancer, and it does seem that that morbid obesity, or BMI greater than 35 or 40, depending on how you wish to define that, appears to be associated with increased rates of thrombosis in these patients. The event rates are pretty small. It's actually thrombosis or sort of overt, as opposed to the microthrombi, which we do think affect most patients with COVID-19, but the overt thromboses only occur in, I believe it was 2 or 3%. So it's relatively uncommon, but even so, we still see indeed that morbid obesity appears to modify that risk.
Thank you. Going down the list of questions, Dr. Warner, any chance some of these data could be used to get cancer patients the vaccine more quickly, or to make an argument, or how would you view that?
Yeah, so I try to be busier on Twitter, but certainly others that are busier than me have had a lot of discussion about the fact that patients with cancer were more or less systematically excluded from the vaccine trials. And so either because of that history or other exclusion criteria, such as being immunosuppressed or on some kind of recent therapy, such as chemotherapy. So we need to know, obviously, a lot more than we know right now, both about efficacy and safety. And certainly we hope to utilize the apparatus that we've built to collect that information. We have a new variable that went up yesterday since Canada approved the Pfizer vaccine. I don't think they've actually started administering it yet, but as soon as that went through, since we have sites in Canada, we've opened that new variable. Perhaps later today we'll be thinking about the United States as well. But
yes.
So I think we'll have to collect that information, and we're not going to know right away, but hopefully in the next few months. I treat patients with hematologic malignancy. I'm very concerned about their ability to mount an appropriate a response or an immunologic response there, but that doesn't mean they shouldn't get the vaccine. I guess there's a question of prioritization, which is inevitable when you don't have enough doses for the total population. But certainly the people around them, and this is what we advise for flu vaccine and all the others, really, like in patients who've gone through a transplant. We always advise that their local herd, if you will, or sort of the locals, everybody who might have contact with them should absolutely get immunized so that they can get secondary protection.
Right. Dr. Popkin, I don't know if you want to address any of the issues with the vaccine efficacy with cancer patients, or
we can't.
Thoughts?
We wish we could, but it's impossible. I mean, again, if it would be ideal, at least that they, at a place like Vanderbilt, they took a subset of patients and tested the vaccine to see how it would work without side effects and so forth, because we don't know.
Right. Just don't know. And Dr. Popkin, again, you talked about efficacy of the vaccine for obese individuals, and the fact that the vaccine trials, you're unable to disentangle that. Do you see that as being possible in future? And are there plans?
The data's there. They can do it. And in the U.S., the U.K., clearly with 35 to 40% of the populations being obese, it'll be quite easy. And then another 40% being overweight. In all the high-income countries where the tests have been done, we have such huge populations, they'll have the data because they only excluded people with some extreme issues like serious cancers.
Yes. So those analyses are yet to be done. They will be possible to be done in your opinion. Post-hoc, wonderful, great. Going on to additional questions here, Dr. Warner, have you done any sensitivity analyses where you actually exclude patients you suspect are catechic? And do you have information about recent weight loss for your patients to better assess this?
I mean, I think that's what we'd have to do, right? So when I looked, I looked at those numbers and I saw those trends, and I saw, clearly the patients with poor performance status being relatively underweight. I do think we would have to do it. It very quickly becomes obvious that even a database of 6,000 patients is not sufficient once you start dropping large portions of it. But like I said earlier, unfortunately, I believe we'll soon be above 10,000, sort of by our internal estimates. It's really a question there of statistical power. We certainly wouldn't want to try to make any claims of non-association if the power wasn't sufficient. So it's a fine line there. And of course, there's all the caveats of retrospective cohort studies, which we cannot forget. But that all being said, certainly that when I think about the next steps from what I showed you on those violin plots, that's definitely the next step, is to try to zero in on a population that isn't clearly having cancer cachexia or related issues. But I do say. There's another side of that coin, which is the patients who are gaining weight because of their cancer treatment. And that's also, I would actually ask Dr. Popkin to comment on this. I mean, these are patients that were not necessarily obese for years or even longer. These are people who've gained 20, 30 pounds as a result of the steroids they get for their chemotherapy. It doesn't tend to come off though, but it's almost more of a transient obesity in this case. And I wonder how that's different.
Dr. Popkin, do you want to speculate?
I don't think none of us can speak to that issue at this point.
Right. There's so many unknowns here. I have a question actually for both of you. Dr. Popkin, do we know anything about the risks in children? Have there been studies done or any data gathered?
Yes, we looked at children's data, and particularly among adolescents, there's the same effect as in adults. If you're obese, that is, of course. Yes. We don't have data from children but under the age of 12, no. Post-puberty, yes. All
right. Okay. Is there any hope to be gathering such data to understand?
We don't have enough cases with preschoolers, obviously. Yeah. And school-age children, the numbers are so small that I would hate, even nationally, you put them together for children 6 to 12. I would hate for us to try to do analysis with samples like they are, but it could be done. It can certainly give us the relationship, and you can do odds ratios, but we won't have enough of these studies from around the world. I know also from my colleagues doing clinical work in Brazil and Mexico, some of our team are like the czar of COVID in Mexico, and it's the number of children coming into the hospitals is really minuscule compared to the adults and the adolescents, and very few adolescents.
Right. Dr. Warner, do you have plans to expand data collection and assessment to pediatric cancer patients? So similar question, those under 18.
Yeah, it's an interesting question. I mean, first of all, fortunately, pediatric cancer is uncommon. I mean, it gets a lot of attention, and rightly so, but it is fairly uncommon. And when you look at the sort of intersection of an uncommon cancer with still an uncommon infection, I mean, it's out of control, but still it's not, it's some small percentage of the country. The numbers do get small. Additionally, for that reason, and sort of in spite of that reason, we are very sensitive to re-identification concerns. So although our database is de-identified, we've gone sort of beyond HIPAA, if you will. We don't even disclose geographic region at the level of states, when we share our information, because we just really are sensitive to this possibility. So for those reasons, we're currently not accepting reports for people under the age of 18. But I do believe the NCI prospective trial, the NCCAPS, and perhaps some others are collecting pediatric cases. So I hope that one of those other efforts that may feel more comfortable about this, or may have a better way of basically preventing any possibility of re-identification, might help us learn more about that.
Thank you. And just a clarifying question: does your consortium include cancer patients who are not diagnosed with COVID-19, or only those who have both?
Well, we collect presumptive cases, so we do have a small, I have to say the vast majority, both in this country and outside, are confirmed by PCR. You have SARS-CoV-2, but we will take reports of presumptive cases of COVID-19. Does that answer the question?
Yes, yes, believe so. Dr. Popkin, you talk about this, and it seems these unhealthy behavioral patterns that have been established with less physical activity, more unhealthy diets. The speculation is that will increase rates of obesity and obviously continuation of those patterns. But I'm wondering if those countries that have gotten more on top of the pandemic. So I'm thinking New Zealand, Australia, some of the Asian countries, Are we seeing a reversion to some of the prior patterns of behavior, and perhaps this is a temporary kind of thing, or are we seeing, or is it too early? It may be too early to even say.
Well, first of all, the data coming from colleagues in Australia and New Zealand is they're responding the way the rest of the world is, except now they're back to more normal living in both countries. And Australia had a short blip when they had to be more careful in Melbourne and a few areas, but and then it's a question of what they ate before, because they're working, doing everything normally in New Zealand. So we don't know from them. We certainly know from Europe that they're functioning just like Americans, eating more junk food and beverages, being much less active. And so the situation's going to be the same. We're going to see these 10, 20, 30-pound weight gains during COVID from many populations.
Right. And the question is, again, do people then go back to healthier behaviors, and perhaps we then see trends to a reduction?
It's much easier to prevent weight gain than it is to lose weight. It's purposeful. And for much of the population, I think it will be very difficult to go backwards. So I think a year from now, 2 years from now, the NHANES data are going to show us significant shifts to the right in our weight distribution and BMI distribution across the country in all ages.
Wow.
But we'll have food insecurity as well. So what this has meant is people are buying more perishable store foods that are not perishable. They're certainly shifting more to unhealthy foods in general. And we'll have data on that later, because we get from 60 to 90,000 people in the country, households, daily food purchases. So we'll know subsequently, but it'll take time to understand, and it'll be too late for now. And obviously, we don't have a government pushing toward healthy living and eating at all. So we're in a difficult situation that way. And that's true. Only the UK has come out of this with active interventions to deal with weight. They've cut marketing. They've done a number of things during this and talked a lot about weight increases and healthy eating. And that had a lot to do with Boris Johnson's complications from COVID and coming out of it with that push. And he unleashed the government to do more.
So it's interesting, there'll be almost a natural experiment in a sense to take a look at what the outcomes there in terms of weight. Thank you. Dr. Warner, we have a question from a medical oncologist at Yale who's noted in non-COVID individuals during pandemic, an apparent marked increase in more aggressive, rapidly growing tumors, specifically in early stage breast cancer, presenting in stage 3. So is the consortium looking at the impact of COVID pandemic, including this increased obesity potentially, but also stress and inactivity, on more aggressive tumor behavior?
Well, that unfortunately sounds like perhaps someone who delayed screening, which is clearly a thing. I mean, some reports have found over 90% decreases in the rates of elective screenings, mammograms, colonoscopies, and so forth. And so I think there's this widely anticipated and feared upstaging, if you will, of cancers broadly. The NCI, I know, is extremely concerned about this. On the flip side of that coin, right, cancer diagnoses, I mean, this is now starting to emerge, that cancer diagnoses this year are down by half. Well, that's not because cancer went away, right? We all know that. And so I think COVID or not, I mean, people are changing their behaviors, and that includes decisions about screening or decisions to get symptoms worked up too. So I think that's probably what, I'm not sure if that's what the question is getting at. I think there is a separate question about whether this virus has any effect on cancer, on its on its pace of progression or transformation, perhaps. I don't believe there's any basic science to suggest that this is a virus with transforming potential, similar to much more well-known viruses that are associated with malignancy. But I think time will tell for that as well. We've gotten at least a few sort of anecdotes that have come through our consortium about patients who may have acquired a second malignancy, unexpectedly, sort of around the time of the virus. So I don't know, but I don't think those anecdotes will answer that question. But I do think, again, the combination of lowered screening, increased obesity, more sedentary lifestyle, none of these things are going to be good for cancer incidence or for stage when diagnosed, unfortunately.
Yes. So, Dr. Popkin, we have a question. Given the known risks of both obesity but also undernutrition, should weight loss be recommended in patients that are not currently infected with COVID-19?
It really depends on the subpopulation. In our country, absolutely. And actually most of the low and middle income world, because the patients and the individuals in urban areas have moved their diet so much to less healthy eating that we need to find ways to deal with that. And so clearly among those who are really undernourished, they're either getting special feeding, and that's preschoolers mainly. Once you're stunted thereafter, it's a different ball game in terms of eating. And yes, there's a few food challenges in each of our countries. And it's very different than it is in the US and the higher income countries. But again, the urban populations are gaining weight so fast that we have to talk about that. And one or two, they are talking about it.
Right. Thank you. And I think we have time for just one more. And this is again along the lines, Dr. Warner, of the long haul or the long-term effects. So given the phenomenon of brain fog in both cancer patients and long COVID patients, has your group discussed the possibility of exploring potential patterns, mechanisms? Do patients that experience this, sort of brain fog have increased likelihood to experience long COVID brain fog? Is that a question you all have any ideas about, or are there common mechanisms associated with these things, do you think?
Well, I've been personally experimenting with the effects of sleep deprivation on brain fog. And spending months at a time in the same house, right? I think there's so many factors, but that's a super interesting question. I've certainly seen patients whose life has been disrupted by chemo brain, and nobody knows why. And I think I'm not sure that remains the case to this day, right? I think fundamentally we don't understand what's going on there. But I do, and again, the steroids are not. Look, the data that came out of the UK recovery trial was great, and I think in the right populations, steroids are the way to go. But you can imagine someone getting high-dose steroids in an ICU on a mechanical ventilator is going to get steroid myopathy, is going to get all kinds of other issues, and they will hopefully survive their COVID, but it wouldn't be any surprise if they have long-lasting effects directly related to steroids and possibly the virus, long-term inflammation, all of these things. So we'll try to collect that data, and we're not the only ones, but we're thinking of we're coordinating with ASCO and other organizations. We're trying to think about what is feasible and practical to collect over time. But that's certainly a great idea. Thank you.
Great. Well, thank you. I want to once again thank the panelists, Dr. Warner, Dr. Popkin, and Linda Nebling for the wonderful introduction. Outstanding talks, so interesting, such good information. And thank you so much. I'll turn it over now once again to Mabinti to close.
Thank you. We are now at the end of our webinar. Again, thank you to our speakers and an audience for an engaging presentation. Even though the audience could not speak, their questions were amazing and keeping the conversation going. As a reminder, a link to the event evaluation will be sent to you shortly. Please complete this short evaluation as it will help inform how we can conduct future webinars. This webinar was also recorded and will be available to the public at a later date. Lastly, we'd like to share our next webinar will be March 4th, 2021, titled Why Are Obese Individuals from Racially, Ethnically Diverse Backgrounds at High Risk for Cancer? The following March webinars are listed on the screen, and the registration link is also listed. Again, thank you so much for attending and have a great day.
Thank you.
Thank you all.